Hello everyone, my name is Dr. Arsalan and I'm an infectious disease fellow at a university hospital in the United States. And the purpose of today's video is to shed some light on the treatment options for the current global pandemic that is COVID-19 infection. I would like to thank the MD's channel for providing me the opportunity for delivering this message on the forum. First of all, I would like to start with the indications for the treatment, and these indications include but are not limited to the patients who are more than 60 years of age, patients who are not on any oxygen at home but are requiring supplemental oxygen, patients who have an immunocompromising condition such as leukemia, lymphoma, or have a transplanted organ, patients who have underlying conditions such as diabetes, heart disease, high blood pressure, uh, cirrhosis, UPD, asthma, and patients requiring ICU level of care. But in the end, it comes down to the clinical judgment of the treating physician that which patient needs to be treated as an inpatient and which patient can be treated as an outpatient and which patient can just be monitored without any treatment. So as we all know that this is a new disease and we do not have any definitive treatment, but there are few trial drugs that are being studied all over the world. The most common one being hydroxychloroquine. The study suggesting the use of this drug comes out of China, showing in vitro success of hydroxychloroquine to inhibit the coronavirus, and it was found to be more potent than chloroquine. There was another randomized trial among 62 hospitalized Chinese patients where hydroxychloroquine was shown to improve the and shorten the clinical recovery. This study was not conducted among severely ill patients. Furthermore, this study is not peer reviewed, so we will have to wait for more data to see whether it is actually effective against COVID-19. Another drug that is being used most commonly is azithromycin, which is basically an antibacterial drug but does have some antiviral effects as well. And the data suggesting its use comes from a small French study where six patients who received hydroxychloroquine plus azithromycin were found to have higher cure rates versus patients who just received hydroxychloroquine or no treatment at all. However, because of the small size of the study, the power is low, and there also seems to be some selection bias as the participants were selected from different hospitals and might have different underlying characteristics. Furthermore, there is known cardiotoxic effects of both hydroxychloroquine and azithromycin on the QT interval, as they both can prolong the QT interval, and this can lead to fatal cardiac arrhythmias. So, if these two drugs are being used in combination, it is necessary that the patient's serum markers such as troponin and CPK should be monitored, as well as, if possible, serial EKGs should be conducted on these patients. And these drugs should be avoided in patients who have underlying QTc prolongation. Another drug that is being used most commonly, I will say not most commonly, but is part of a phase 3 clinical trial, is Remdesivir, which is an antiviral drug and has been previously used against Ebola virus, SARS, and MERS, though the outcomes for Ebola virus were not favorable. However, this drug does have a favorable safety profile in humans. It has been shown to have in vitro activity against SARS-CoV infection, and so far 53 patients data has been published, and 22 of which were from the United States, 22 from Canada and Europe, and 9 from Japan. Out of these 53 patients, 36 patients actually improved, 17 of which were mechanically ventilated and eventually were extubated and discharged to home. So there is some hope that this drug might be beneficial, but we have to wait for more data before we can actually say that this drug actually made a difference. Another drug that is being used most commonly is Tocilizumab, which is basically an interleukin 6 receptor antagonist, and has been used in China in a case series of 21 patients with positive outcomes. And most of these patients were severely ill. The basis of using this drug comes from an observation of elevated markers of inflammation such as ferritin, ESR, CRP, and inflammatory cytokines, actually suggesting the role of hyperinflammatory response in COVID-19 pathogenesis. Furthermore, one of the studies in China showed that non-survivors were found to have significantly higher levels of IL-6, that is interleukin 6, versus survivors, further suggesting that COVID-19 leads to a hyperinflammatory response within the body. Before using tocilizumab, it is essential that we check the serum markers such as CRP, ferritin, D-dimer, and also check a T-spot, because this drug is contraindicated in patients with active tuberculosis infection. Now, at my hospital, initially we were using this drug for severely ill patients, but we've seen that this drug might be more beneficial if we give it to patients who we anticipate will develop severe disease. So if a patient who is coming with a prolonged course, such as at least 7 days of illness, patients who are in visible respiratory distress, such as using accessory muscles of respiration or are not able to speak in full sentences, patients who are tachypneic and whose oxygen requirement are worsening, might benefit from this drug more than patients who are already mechanically ventilated, are on pressors, or are developing worsening organ failure. Tocilizumab is also contraindicated in patients who are receiving remdesivir, and pregnant patients and breastfeeding mothers. The dose of tocilizumab is 8 milligram per kg, and if no improvement is seen after the first dose, a second dose can be given. Another drug that we have started using is N-acetylcysteine, which is a mucolytic agent, and the reason for its use is that there seems to be development of small mucus plugs in patients with COVID-19 infection, and an early use can prevent these mucus plugs and prevent the development of ARDS. The use of steroids was initially thought to be controversial and contraindicated. However, if it seems like a patient will develop ARDS, the steroids can be used, and they might be beneficial. But still, we have to see that if there is any more data that shows its effectiveness in COVID-19 infection. Also, another mode of therapy that is being used is plasma therapy, and that is taking plasma from patients who have already recovered from COVID-19 infection and giving them to patients who are severely ill and are not recovering from the disease. So far, we have very limited data. There seems to be some good news from China, where 10 patients received it and recovered. But we do not know yet that if it's going to work in every patient who is severely ill. And another thing that we are seeing in COVID-19 patients is that they are hypercoagulable, as severely high levels of D-dimers have been observed. DVTs have been seen in these patients, and though I have not seen any pulmonary embolism, but we have started anticoagulating these patients with Lovinox, and we are also discharging these patients on Novax. So that's one other thing that should be considered in these patients from the get-go. In the end, I have seen patients receiving vitamin C and zinc infusions. There is no data suggesting its use, but we can see in the coming days if these are actually beneficial or not. In the end, I would just like to say that we are trying our best to treat these patients, and the fight against COVID is ongoing, and we will definitely win in the end. Stay safe and stay healthy.